Hello, good evening, everyone, and namaskar. I'm Dr. Pinky Chauhan, clinical editor with the MedTalks team, and we welcome you to the Dr. KK's MedTalks Live. And today we bring to you episode number 685 of the show. Let us move to the topic of the day. So, to present the talk, we have with us the renowned Professor Dr. Sushmita Bhatnagar. She has served as an honorary consultant pediatric surgeon with Bombay Hospitals Institute of Medical Sciences. Good evening, ma'am.
Good
Very warm
evening.
welcome
Very
to you.
yeah, thank
Yeah,
you.
and she is also serving with associated with Global Hospitals, ACI Kumbala Hill Hospital, and Apollo Hospitals, Mumbai, and serves as a consultant pediatric surgeon there. She has served as an immediate past president with Association of Medical Consultants, has been the chairperson elect and immediate past chairman of Association of Pediatric Surgical Oncology, and is also the director of Focus, that is Foundation for Children's Universal Support. So over to you, ma'am, to discuss at length and elaborate and with us the topic of the day, pediatric solid tumors. Thank you.
Thank you, Dr. Pinky, first of all, for inviting me here, and second, for this elaborate introduction that you've given. So,
Honor, honor.
I have prepared a PowerPoint presentation because there are a lot of things which may not be understood if it is just verbally informed. So, let me share the screen and show the presentation.
Sure, ma'am. So yeah, yeah.
So, can you see the screen with the title? Hello,
Yes,
Dr.
ma'am.
Pinky, just confirm so that I can move ahead.
Not the presentation one, ma'am. It's a different window open.
Okay. Right. Now I think it should be good. Yes, pediatric solid tumors. Can you see the screen? Can you see the
Yes,
PPT?
yes, ma'am. Perfect. It's perfect showing now. Thank you so much.
Okay, great. Just a little bit about pediatric solid tumors. Why we are talking of solid tumors is because there are malignancies or cancers in children are in two types. We will be covering that in the presentation, but just for everyone to understand, there are liquid tumors and there are solid tumors, and we are talking about the solid tumors today, which is increasing in our country, in fact, all across the world. So, what is the before we go on to understanding what is pediatric solid tumor, we must know that what is the difference between the pediatric and the adult tumors or cancers overall. So the incidence of adult is 538.8, say 539 per 1 lakh population, whereas in children it is 17.6 per 1 lakh. So if we compare this incidence, it is definitely on a much lower side. The risk factors, we know the risk factors in adults such as smoking, alcohol, exposure to radiation, exposure to chemicals, exposure to so many other substances, viral infections, they are causing cancer in adults. But in pediatric, these risk factors are uncommon. The types of cancers are completely different in children versus adults. When we treat these cancers, 75 to 80% is the overall survival in children, which is much better than in adults, which is just about 60, less than 60%. Now, when we look at why these tumors occur in children, the pediatric cancers are derived, they are embryonic and they are derived from the non-ectodermal embryonal tissues, whereas those in adults are carcinomas, which are derived from epithelial tissues. So, when we talk of risk factors, there are preventable causes in adults and preventive measures are effective. But in children, the preventive measures are not effective because the cause is completely different. When we compare the incidence of cancers in children versus adults, we see that, okay, the list of the cancers is over here: acute leukemia, the central nervous system tumors, lymphomas, neuroblastomas, Wilms tumor, soft tissue sarcoma, osteosarcoma and Ewing sarcoma, and retinoblastoma, and so many others. So, of this, only about 10% of the cancer occur in adult. In this list, in the complete set of tumors which occur or cancers which occur in children, only 10% occur in adults, and that too anecdotal reports are mentioned in some from different places. More than 90% of tumors in adults are a different variety of cancers. Now, in children, there is one more major difference is there is a standardized method for categorizing the childhood malignancies, and this is set forth by the WHO. And this system-based malignancy classification on the histological traits of the tumor, that is the type of the tissue, is completely different from that of the adult malignancies, which are categorized primarily according to the tumor site. So, as per the International Childhood Cancer category, there are 12 categories: leukemias, lymphomas, the central nervous system and miscellaneous intracranial and intraspinal neoplasms, retinoblastoma, neuroblastoma, and other peripheral nervous cell tumors, renal tumors, hepatic tumors, malignant bone tumors, soft tissue and other extraosseous sarcomas, germ cell tumors, and other malignant epithelial neoplasms, including malignant melanomas and unspecified malignant melanomas, which occur in just about 5% of the overall malignancy pattern. So, as I mentioned in the beginning of the talk, the cancers are broadly divided into two groups: the liquid and the solid. Now, the liquid malignancies are leukemas and lymphomas, and the rest, all of that list, fall into the category of solid tumors. So, when we look at this graph, which becomes easier to identify, the leukemia and lymphoma are the liquid malignancies, and the rest all are the solid tumors or the solid malignancies. Now, why does cancer or solid tumors occur in children? So, it's been identified that there are some familial and genetic factors in about 5 to 15% of the patients. As mentioned, for adult, the environmental exposure and exogenous factor is just about less than 5%. But a huge majority of these cancers or the childhood solid tumors are having an unknown causation, unknown etiology. That is up to 90%. 75 to 90% of the childhood cancers or solid tumors, we really don't know still why did they occur. When we look at the chromosomal or the genetic causation, it has been found that there is oncogene, which is a gene that promotes cellular growth. And there are three ways or three methods in which this oncogene can cause malignancies or tumors. One is deletion or point mutation. Second is gene amplification, which wherein there is multiplication of the gene. And one is translocation, where the gene removes itself, one of the segment on the DNA is translocated to another segment, and that causes malignancy or solid tumor. If we look at this, there are three steps: initiation, promotion, and progression. Here, the tumor suppressor gene is also one very important aspect. If there is a deficiency of tumor suppressor gene, or if there is a deletion of tumor suppressor gene, these cells, the DNA, they overgrow, and thus they form or progress to formation of cancer. With the tumor suppressor gene working, the DNA repairs, and there is no evidence of any malignancy. So, general approach to all childhood cancers is in three. We have to ask three questions: what is it? Where is it? And where can it go? And answer to any one of these questions will help answer the other two. How? We will look at this right now. So, when we talk of pediatric solid tumors, the pediatric cancers, these are the six, seven phases that we need to remember. One is the diagnosis. Diagnosis includes the stage and the grade of the tumor. Both of these are very important for initiation of treatment. Initiation of treatment is just the beginning, but maintenance and completion of the therapy, which leads to remission, is or stabilization of the illness, are extremely important steps. Once the therapy is complete, we can expect long term survival and cure. If the tumor is very high grade or not appropriately treated, or the patient has not really taken the treatment as per the protocol, there could be relapse, there could be deterioration in the condition of the child. If the tumor is completely taken care of, there is complete cure, we can rehabilitate the child and restore him back into the society with his studies and with his education going on. There could be terminal illness and death, and post death adjustment of the family is also very essential step from which we cannot really get away. Now, diagnosis is always based on history, clinical features, and investigations. What investigations can be done will be based on what are the clinical features. The patient has fever or weight loss, anorexia. Fever is not there in all cancers or all solid tumors. Weight loss, anorexia is there in almost all of the tumors. Lump may or may not be palpable. There may be bleeding from multiple sides. There could be hematuria. Say, for example, a kidney tumor or a bladder tumor will give rise to hematuria. There will be generalized weakness in almost all the tumors. And as per the organ of involvement, for example, if it is in the eye, there will be bulging of the eye or there could be pain. If it is a brain tumor, there could be vomiting, there could be headache. If it is a liver tumor, there could be a palpable lump with jaundice or without jaundice, and so on and so forth. So, based on the site of involvement or organ of involvement, the symptoms and signs, the clinical features are going to be different. Now, investigations play a very, very important role in the management, the entire protocol of any solid tumor in children. One is there are four major aspects: general, that is our routine blood test, urine test. Tumor markers form a very important part. Now, all tumors do not have tumor markers, but there are some tumor markers which are either specific for the tumor or they are general, which could just give us like LDH, which could just give us an indication that there is a malignancy which is there in the body of the patient. For the primary site, for the location, for the extent of the tumor, for the involvement of the structures around the tumor, we have X-rays. You know the whole gamut of investigations, the radiological investigations, X-ray, ultrasound with Doppler, CECT, that is contrast enhanced CT scan, MRI, and some other scans related to the specific tumor like MIBG scan. The type and grade of the tumor is also an extremely important tool in the investigations, which can be achieved by biopsy. Biopsy can be done either with a true cut biopsy, fine needle aspiration biopsy, a true cut biopsy, a gun biopsy, or open biopsy, depending on the site of the tumor and the accessibility of the tumor to all these other non-invasive mechanisms or minimally invasive mechanism of biopsy. Following biopsy, obviously, we need to do histopathology. Histopathology could be a regular histopathology or with special stains. Immunohistochemistry plays a major role in solid tumors, pediatric solid tumors, and electron microscopy if regular histopathology is not able to give us a proper diagnosis. Here, the grade of the tumor, which is from low malignancy to high grade malignancy, can be evaluated, and also the type of the tumor. For example, if it is a renal tumor could be WIMS tumor, which is the most common type, or non-WIMS. Non-WIMS could be many other types of tumors, the differentiation of which is extremely important. All kidney tumors are not WIMS tumor, and the therapy, the treatment for all of these is not the same. So identification of the type as well as the grade of tumor is extremely important. And then every patient should be worked up for metastasis. Metastasis can be evaluated by X-ray, CT scan. Like for example, there is metastasis to the lungs, an X-ray of the chest, a CT scan of the chest is important. Neuroblastoma metastasizes to the bone, so a bone scan, bone marrow biopsy, and other investigations or other scans or imaging, PET scan, for example, can be done based on the type of the tumor. So when we are investigating, it is these investigations are not done one after the other. They have to be done all simultaneously. So these four categories have to be borne in mind when we are investigating any child with tumor. So if there are the two issues here. One is there is a delay in presentation, that the patients or the parents are not able to identify what exactly is the issue, and they come late, they present late when the child is already in a higher stage of the disease. So stage and grade both are important. And another is when the patient presents with some symptoms, but the clinician who is attending to the child first is not able to diagnose. So we need to be aware of these problems and there prevent the delays, because there are number of problems with delay. Because the size changes, the tumor progresses rapidly, there is involvement of surrounding organs, and in a child obviously, supposing if it is an abdominal tumor, there are the extent of the tumor will definitely very rapidly involve other organs. For example, right side renal tumor, upper pole, will involve the liver very rapidly. It will not, you will not have enough time uh, for arresting the progress of the disease. Then the grade will also change. The tumor over a period of time becomes more and more malignant unless it is benign to begin with. In fact, some of the tumors which are benign to begin with also turn malignant over a period of time if neglected and not treated in the early stages. The stage also changes. I'm sure you all are aware there are four stages. Stage one is a small localized tumor. Stage two is involving the surface, or all tumors will have different staging, but this is just overall. Stage 2 is again localized tumor with probably just the surface involved, and stage 3 is extension into the local tissues, infiltrate structures which are adjacent to the tumor, and stage 4 is metastasis to the different parts of the body. So, as when there is a delay, the stage also will change. Obviously, the tumor, which is stage 1 to begin with, is going to become stage 2, 3, and 4 over a period of time, thus requiring much more aggressive treatment. And the patient's condition also could be progressively worsening, as there are other associated symptoms and signs, just like anorexia, the child is not willing to eat, or intestinal obstruction which develops because of an abdominal tumor. So there should not be delay with treatment of pediatric solid tumors. How do we solve this? We need to suspect any child who comes with vague abdominal or thoracic symptoms. we must do appropriate investigations, and obviously following that prompt referral so that the problem is taken care of at the earliest. So, general principles of management of pediatric solid tumors are surgery, chemotherapy, radiotherapy. These are the three main. And then there are immunotherapy and some other advanced treatments, and there are some clinical trials as well which are happening. Now, surgery it is written first, but surgery is not necessarily the first modality of treatment. Many a times, chemotherapy has to be given first. The size of the tumor and the spread of the tumor or the extent of the tumor is reduced by chemotherapy, and then surgery is done. Sometimes radiotherapy is done first, though it is very rare in children that radiotherapy is the first modality of treatment. But the assessment of the type of the tumor, the extent of the tumor, only will decide as to which modality is to be utilized first. Also, it will depend on where is the tumor for us to decide which modality of therapy is to be utilized first. So, let's look at the different types of tumors. The first one I'm referring to is the brain tumor, the central nervous tumor system tumors. 23-month-old female with ataxia. She was falling off again and again for 1 month. She had vomiting for 2 weeks, seen by GP, and gastroesophageal reflux disease treatment was given. There was no improvement, and the vomiting was increasing. Following that, after about 2-3 months, an MRI of the brain was done, and there was a large tumor, as you can see in this picture. A large tumor was seen on MRI. See, this is the tumor. So, what are brain tumors of childhood? They are heterogeneous, where they arise from the glial tissue, neural tissue, or a combination of both. They arise 50% occur in posterior fossa and 50% occur in supratentorial region. Clinical presentation depends on the location and the age. If it is infratentorial, it occurs mainly in less than 6 years of age, and supratentorial ones occur in more than 8 years of age. So, non-localizing signs of brain tumors are the increased intracranial pressure, where there is hydrocephalus, there is obstructed flow of cerebrospinal fluid. Sometimes the child is asymptomatic unless hydrocephalus reaches to such a stage that it causes very high intracranial pressure, causing the signs and symptoms of raised ICT. Medulloblastoma, for example, can grow to very large lesion before it is detected. The signs and symptoms of raised ICP are headaches, which are progressively worsening, vomiting, which occurs mainly in the morning because during lying down position the ICP is raised. There is irritability, there is papilledema. Papilledema for diagnosis, the anterior fontanelle has to be closed. So that is why in more than 18 months of age or about 2 years of age, you will be able to see papilledema. There could be double vision with sixth nerve palsy, and there could be tilting of the head, bulging of the fontanelle if it is a small child. And in a young child with the brain tumor, the head circumference has to be measured because that will also give an indication of the size or increase in the size of the tumor and hydrocephalus as well. The supratentorial tumors, the signs depend on the location and the age, and like in addition, in a younger child, developmental delay or loss of milestones occur, and in older child, deteriorating school performance and personality changes occur. There could be endocrinopathies which could develop, and this can also lead to the diagnosis of tumors, supratentorial tumors. Another one which occurs in newborn babies because it is a congenital tumor is a sacrococcygeal teratoma. So this bulge, this is the buttocks of the baby. This is normal side. On the left side that you see is normal. The right, the bulge that you see is a tumor. And this is the CT scan showing the tumor in the thing in white is the tumor. So many a times these sacrococcygeal teratomas is bulging outside more than inside, and when it is external, that is the Altman classification that has been mentioned, the tumor is I'm sorry, there was a phone call. The tumor can be easily seen and it could be operated and removed completely. We need to be very sure that this tumor is not malignant. If it is malignant, then the baby has to receive chemotherapy as well after the removal of the tumor. If the tumor markers persistently remain high even after removal of the tumor, it could be the sacrococcygeal teratoma could be bigger than the size of the baby as well. So we need to be very, very diligent in managing these babies who are born with tumors. So, as the name suggests, the sacrococcygeal teratoma arises in the sacrococcygeal region. It is the most common tumor of the newborn babies. There are three grades from benign to malignant, and the most of them are benign. There are four types of tumor, wherein the type 1 is the most common. The type 1 is what we have seen in the photographs here. An important tumor marker for this type of tumor is alpha fetoprotein. Antenatal detection is possible and it is necessary for planning the mode of delivery and also assessing the associated congenital anomalies. As you saw in the pictures, if such large tumors are not diagnosed antenatally, so antenatal ultrasound is very important not only for diagnosing other anomalies but also for diagnosing tumors in neonates. Mediastinal tumors could be of various types or various pathologies. They could be completely cystic or they could be solid and cystic components. These are the X-rays and the CT scans of patient with mediastinal tumor. It could be the tumors occur either in anterior mediastinum, which are thymomas, lymphomas, germ cell tumors, and teratomas. The middle mediastinum, most of the times they are lymphomas and cysts. And in posterior mediastinum, neuroblastomas, esophageal tumors, and neuroenteric cysts, which occur in children. Liver tumor, the most common liver tumor is hepatoblastoma. The CT scan of this is visible on the screen, which shows normal liver tissue on the lower side and uh, in the coronal plates, and a lot of tumor in the liver. So hepatoblastoma occurs in about median age is about 1 year, and it is liver is the most common site of epithelial tumors. It overall 0.5 to 2% of all pediatric tumors, and it is associated with maternal use of oral contraceptives, alcohol, petroleum products, smoking as well to some extent. And the treatment is variable depending on the staging of the tumor, depending on the histological type of the tumor. Obviously, all these tumors are not only treated with chemotherapy. Surgical excision, including the excision of the complete liver, which means that liver transplantation is another important aspect of treatment or management of liver tumors, especially hepatoblastoma. Now we come to teratomas. We have seen sacrococcygeal teratoma. Teratomas occur at many other sites. This is an abdominal picture, CT scan, showing a large solid cystic teratoma, and you can see a small structure in the within the teratoma, which looks like a small baby. So this condition is called fetus in fetu. It is quite a rare condition, and identification and surgical removal of this type of tumor is necessary. So, teratomas can occur in very many sites, including the lungs, including the thoracic cavity, including the head, including the buttocks, anywhere on the body. There is one more important site for occurrence of teratomas, which is the retroperitoneum. So the patient comes in with a huge belly. Most of the times they don't have any other symptoms, but a large protuberant abdomen with a palpable lump is what diagnoses retroperitoneal teratoma. So these retroperitoneal teratomas could be benign, they could be immature, or they could be malignant. So there are multiple ways in which these children can present. And if it is a malignant retroperitoneal tumor, then obviously chemotherapy has to be given either before, that is the neoadjuvant therapy, or after surgery, that is adjuvant therapy. Now, germ cell tumors are teratomas, germinomas, embryonal carcinomas, yolk sac tumors, and choriocarcinomas. They arise in the gonads, or sometimes they occur in extragonadal sites such as brain, face, neck, mediastinum, retroperitoneum, sacrococcygeal region. So, there are many tumors which can occur in the brain. There are many tumors which can occur in the neck. So, only looking at the site of the tumor, it cannot be diagnosed as to the type of tumor, cannot be diagnosed in children. So, gonadal tumors here you can see the first picture is of the ovarian tumor, the second one is testicular tumor, the excised specimen is testicular tumor. There is just marginal increase in the size, but this is testicular teratoma. Now, coming to kidney tumors, Wilms tumor is the most common type of renal tumor. Over here it is marked out a small tumor, but this is appearing small only because this child has received chemotherapy to begin with, upfront chemotherapy as per the SIOP protocol. Following chemotherapy, the upper pole of the kidney, the pelvis, and the upper ureter is showing tumor, and this entire specimen has been removed. The entire ureter and the entire kidney has been resected. So Wilms tumor could be of any sizes, just like you see over here. They could be various different ways in which they present. Lump will completely cachexic child. So when the child is neglected, yes, the tumor becomes very large and the child is completely malnourished. So Wilms tumor was first described by Max Wilms in 1899, and it is the most common tumor in children arising from the kidney. 50% of these cases occur before 3 years of age and 90% occur before 6 years. Occasionally, they occur in extrarenal locations such as retroperitoneum, sacrococcygeal area, testes, uterus, inguinal canal, and mediastinum. Again, that is why I mentioned if it is a retroperitoneal tumor, it does not necessarily mean that it would be retroperitoneal teratoma. So, histopathology is extremely important to diagnose what is the type of the type of the tumor and what is the grade of the tumor. Another tumor which occurs just above the kidney is neuroblastoma. It occurs in the adrenal glands, which is the most common site of this tumor. So they are large tumors many a times because they arise from the retroperitoneal region, and by the time they are diagnosed, they are pretty large in size. This picture on the right hand side shows a complete excision of the tumor with the aorta, with the renal vessel, which are hooked, with both the right and the left iliac vessels, which are clearly visible. So, neuroblastoma is the second most common solid tumor in children. It is a tumor of the sympathetic nervous system. It produces catecholamines, which can be measured in the serum or urine. As I mentioned earlier in investigation, these catecholamines become the tumor markers for neuroblastoma. They arise in the adrenal gland or from the sympathetic ganglion. Chromosomal abnormalities have been identified, such as 1p deletion, 17q, and MYC amplification has been well known all across the world. A spontaneous regression in stage 4S. This is one tumor where there is a additional stage, that is stage 4S, wherein the tumor completely regresses on its own. It occurs mostly in infants, in children who are less than 1 year of age. And when there is a ganglioneuroma, which is a benign tumor, it can be either excised or it may be just left alone if it is a very small tumor. Then there is rhabdomyosarcoma, which arises from, it is a type of soft tissue sarcoma. So soft tissue sarcomas are of two types. One is rhabdomyosarcoma and another is non-rhabdomyomatous soft tissue sarcomas. Here, the one in the picture in as a palpable lump is a bladder tumor. The one in the CT scan is also a bladder tumor, which is arising from the dome of the bladder. Rhabdomyosarcomas are highly aggressive and malignant soft tissue tumors of mesenchymal origin. They can occur at innumerable sites in the body. Most common of these is genitourinary. 70% occur in children less than 6 years of age, and mid-adolescence there is another peak. 70% of the children survive 5 or more years after therapy, and here also chromosomal deletion 2 and 13 have been identified. There are three histological subtypes which affect the prognosis to a great extent. And many groups, many cooperative groups have tried to study this tumor in detail. The International Rhabdomyosarcoma Study Group. The sites, as mentioned, genitourinary is more common. It occurs in the orbit as well, head and neck, non-orbital tumors, mediastinum, trunk, retroperitoneum, paratesticular, and in extremities. The signs and symptoms vary as per the site of the tumor. If it is genitourinary near the bladder and the prostate, it occurs with the hematuria, urinary obstruction. If it is paratesticular, it is increase in the size of the testes. If it is vagina in the uterus, then there is an abdominal mass or a vaginal mass for vaginal bleeding and discharge. And it can show up in any other site. It can show up on the face. A small baby 6 weeks old with a lesion which anybody could feel that this could be just a boil or an infection, but it is a tumor. It is a high grade aggressive tumor. It can occur on the scalp as in a newborn baby that you can see over here, and it can occur in the extremities. This tumor looks very similar to rhabdomyosarcoma, but this is a non-rhabdomyomatous sarcoma, soft tissue sarcoma. This was completely excised, but because it was a high grade malignancy, this was a 1 month old baby, and in a high grade malignancy with a forearm sarcoma, the baby was advised chemotherapy. The parents felt that the tumor has been completely excised. What is the need to take chemotherapy? And then he came back with a large tumor recurrence. And this tumor then had to be excised completely with amputation. There are other types of tumors, which undefined tumors or malignancies which can occur anywhere in the body. This huge one, it was not allowing the baby to swallow saliva as well. Forget about having food or anything. Large oral tumor. Other tumors which can occur in the extremities or in the abdomen and in the stomach, which is gastrointestinal stromal tumor. This child had partial excision of the stomach along with the tumor. Then there are bone tumors which can occur like a mass, present as a mass or pain or fracture at the site of bone destruction. So there are two types of bone tumors: the osteosarcomas and the Ewing sarcomas, and the outcomes are variable depending on whether or not metastasis is present at diagnosis and location. This is first picture is of the X-ray with the tumor, and the second one is MRI of the knee joint. Obviously, this patient would have had to undergo amputation. So this is a little bit in detail about differentiation between osteosarcoma and Ewing sarcoma. Maybe I can skip this. It is not really required. Retinoblastoma is the tumor of the eye. Here in the picture that you can see is the left eye, which is much larger than the right. And even when you look at the child, you can see that there is a uh, it's like cataract, the white pupil is not cataract in children, it is retinoblastoma. There could be excessive watering of the eye, there could be strabismus, there is lack of pain obviously, because there is generally no glaucoma or inflammation, but if it is there, then there is pain. And ophthalmological examination confirms the diagnosis. So this is the most common intraocular tumor of childhood. It occurs in about 3% of all childhood cancers. And median age at diagnosis is 2 years. 90% of the cases are diagnosed before 5 years. So to conclude, over 70% of children diagnosed with solid tumors can be cured of the disease, which is a very, very positive thing. In India, we don't really have the figures, but in USA, 1 in every 1,000 young adults alive is a survivor of childhood cancer. In India, we can achieve this too. So, children should be followed throughout adulthood for potential late effects of therapy and second malignancies. There are some special areas which have to be looked at. Just it's not just about uh, surgery or chemotherapy or radiotherapy. Nutritional support is extremely important. Prevention of infections which occur during the phase when the patients are getting chemotherapy. Financial support, because treatment in our country is not really completely free, or it's not it is expensive to some extent. Psychological support to the child as well as to the family, because many a times, because of prolonged treatment, many a times the family, the parents lose their jobs, they lose they lose their house, they lose their homes as well, so many times. And rehabilitation of the child and the entire family in a way is an extremely important matter which many times gets neglected. So thank you so much for being here. Please remember that unless we teach it, we can't treat it and we can't beat it. So let's all together beat childhood cancer, because cancer in children is curable. Thank you so much. So, are there any questions? There are some comments, but there are no questions, it looks like. So remember, all of y'all, before we say goodbye and good night, have a happy weekend. Before that, remember, teach it, treat it, beat it. That is our motto. And we, Association of Pediatric Surgical Oncology, I am the chairman elect and the immediate past chairman of this association. And we want to do a lot for these unfortunate children who can be well, who can lead a good, productive life. And we together only can give it to them. Thank you so much again for being here.